Vice Chancellor for Strategic Initiatives for the Texas A&M University Health System. Feel free to put any questions in the chat and we can get them answered in a Q&A session. So Mr. Hartman, feel free to take it away.
Okay, thanks. I appreciate you guys doing this, doing it at dinner time. That's really appreciated. So thanks for inviting me. I really would like to see, questions you guys may have. Me talking for, 30 minutes or an hour would be probably not only boring to you, but would be really boring to me as well too. So please ask questions. And I'm more than happy to talk. What I'd heard is, I'll talk a little bit about kind of my career, how I got here, talk a little bit about the Health Science Center. Obviously, there may be questions about COVID and vaccines and all those kind of things. It seems like these days, that's what I'm spending almost all my time dealing with is COVID stuff. So be happy to talk about those kind of things. And then I know all of y'all are, looking at healthcare careers or whatever, would love to talk about that and help in any way I can to think about that. So I'll sort of start with that. What's interesting sometimes when people want to talk about my career, it's always a little surprising, is I didn't really expect to be in healthcare at all, to be honest. And for me to have this job that I have now is a little bit of a surprise, although I've been doing some stuff that kind of led up to it, I guess. So, when I was in college and then just out of college, I did a lot of work in the state legislature, worked on public policy, and actually ran political campaigns. And I ran a whole variety of different kind of political campaigns, everything from school bond elections to candidate campaigns, working for people running for the state Senate and those kind of things, all around the state of Texas and a little bit around the country. And that's actually how I met John Sharp, who's the chancellor of Texas A&M in the mid 1980s, or I guess late 1980s, which I know none of y'all were born there, and it sounds like ancient time, but he was a state senator who was running for statewide office in Texas to be the state controller, which is the chief financial officer for the state of Texas. And so he asked me to run his campaign, which he won, and then he asked me to serve as one of his deputies. And so I worked at the state controller's office for several years for him, got to do a lot of really interesting stuff where I learned a lot about, not only was I managing a lot of people, but we started the Texas lottery while we were there. At that time, there wasn't a lottery commission. The state controller's office ran the Texas lottery. So we were there to set that up. At the time, it was the largest lottery in the world. And it was actually the most successful 24-hour startup of a lottery. So it was really cool. And that was not so much that we did a great job, I think it went well, but it was just, there was such a demand in Texas. It was really kind of fascinating to do that. Learned a lot about marketing and advertising. I did that for several years. And then I went to work for a national management consulting firm that did a lot of work in the public sector, in the higher ed world, but also private sector. I did some international work in Argentina and in Europe, basically doing sort of management consulting kind of work in a variety of different settings. I did that for about 10 years and was also really lucky there because I got to run a company or be a part of running a company, a senior partner in a company that started pretty small. I was the 36th employee in the company. And by the time I left, a little less than 10 years later, we had grown to about 360 people. So got to really see what it's like to grow and how do you develop a company like that. Did that, then I moved to another company that did corporate communications strategy, corporate strategy kind of work all around the state of Texas. Did that for several years, and then was asked to join Seton Healthcare down in Austin, Texas. I don't know if many of you have heard of Seton. It's a part of Ascension Health, which has been the largest not-for-profit healthcare company in the country. I think it's now number 2. I think a couple of other not-for-profits got together, but it's a faith-based not-for-profit hospital company. When I went there, it only had 3 or 4 hospitals. I think now Seton has about 13 or 14 hospitals. I ran what used to be called Brackenridge Hospital and then University Medical Center Brackenridge, and then actually helped to start and build the Dell Seton Medical Center, which was right across the street. They're actually tearing down the old Brackenridge, but I built a new hospital, and then I ran Seton Medical Center on 38th Street for many years down in Austin. So did that, did lots of other work in the hospital world, including a lot of work with underserved populations, which I really enjoyed, trying to figure out how to develop ways to provide care to folks who weren't insured. As a lot of you know, Texas is the most uninsured state in the nation. So we have lots of folks who aren't insured, everything from homeless folks all the way up into folks who have good jobs, good blue collar jobs, but still aren't able to afford insurance. So I really learned a lot about how do you put together programs to provide provide care to folks and get services to folks who may be underserved or who can easily drop through the system, and also help to build the Dell Medical School at UT. That medical school is kind of a unique medical school. It's fairly new, a whole lot newer than ours here at A&M, but it was funded through a local referendum of property taxes, as well as some other dollars that came through a central healthcare district. So anyway, created that, did that for about 15 years, and was going to leave Seton. And I did leave Seton, was going to go work for a not-for-profit. And Chancellor Sharp, who, like I said, I've known for a long time and had worked with over the years, called me up and asked me to work as a vice chancellor to work on a variety of services, a variety of different programs, but including the engineering medicine program in Houston to help get it kicked off, and also the Healthy Texas program down in South Texas, where we do population health services. It's a collaboration between the Health Science Center and AgriLife, where we provide services to folks who don't always have good access to different kinds of public health services. It's a really interesting program down there, and we've really grown it and we're doing some new interesting research with the program down there in South Texas. Was doing that for about 9 months, and then Dr. Carrie Byington, who had been the dean of the medical school and had my current job as the chief operating officer, she was hired by the University of California system to go run their health system, the University of California health system. And she and the president of A&M and the chancellor asked me to serve as the chief operating officer interim. And then in March, they asked me to be permanent. And of course, a lot of that came right as COVID was happening. So I've been spending a lot of time we were put in charge of developing not only Texas A&M, but the entire system across the state, all of the testing programs we had, and figuring out how to build out that system, doing a lot of work around that. And now, we've got a team that are figuring out how to get the vaccines distributed across the network and the system, and then also working with the community. We're going to start doing mass vaccinations here in Brazos County, and probably some other places around the state pretty soon. So that's just kind of how I got here. So, it's kind of interesting, people sometimes wonder, what did I do to get this job? It was really sort of dumb luck, being at the right place at the right time, working for some people who I've enjoyed working for, being willing to try different things and take things on and getting involved, and just having a real passion for trying to figure out how do you provide care, in all kinds of ways across the healthcare system, but particularly for those folks those underserved populations. It really fascinates me. And one of the reasons I love being a part of A&M, because as a land grant institution, we have a mission to care for our state, to provide services, and to be able to focus on not only high-end care. And we have lots of great researchers who are doing some incredible stuff that can change healthcare in so many ways. But we also have a lot of people in the College of Medicine, nursing, pharmacy, public health, everywhere, who are really thinking about caring for those underserved folks who sometimes fall through the cracks. And I believe there's a way for us to really focus on how do you care for those populations? How do you care for the wealthiest among us? But how do you also create a system that provides care for those areas where that's not true? What I sometimes refer to as austere medicine. I've learned that in the military and also in emergency management medicine, there's this concept of austere medicine. How do you provide great care in situations among populations and in geographic areas where there's not a lot of resources? And that can often be after a flood or a hurricane or a forest fire. It can often be in a battlefield setting, or when our troops go to Afghanistan. There's lots of talk about austere care, but I often wonder if we can do that in crisis situations like that. Why can't we figure out how to take care of populations who sort of live in a crisis situation because of their inability to have insurance or whatever? And so we're starting to do some interesting work to think about what does it take to really build a system that can survive and even thrive, focusing on that population as well as all the other great work we do. So we're in the process of doing some strategic planning for the Health Science Center. Some of you may have heard about that. It's called Vision 360. A lot of work being done right now to figure out, what's our future going to look like? What do we focus on? There's been a lot of agreement that we really should be one of the top health science centers in the state of Texas. College of Medicine and all of our colleges, nursing, pharmacy, public health, dentistry, nursing and medicine, we ought to be one of the top. There's no reason for us not to be in the top tier of the state, and we're actually not right now. We do a lot of great stuff. There's a lot of great teaching going on. We produce a lot of great doctors and nurses and pharmacists and other folks. but there's still a lot of things we could do in terms of research, in terms of our ability to be innovative, that we can expand upon and be even better. And so we're really sort of thinking about what should we be focusing on, what does make us different, how do we differentiate ourselves from the other big health science centers and medical schools in the state of Texas, and frankly, even across the country. And how do we really then, strategy, people outside think strategy is about what are you going to do. Good strategic planning is actually about deciding what you're not going to work on, because you've got to be focused, you have to prioritize, and you have to identify resources to focus on things if you're really going to make a difference. And so this has been it's been a big process, a lot of meetings, a lot of conversations, a lot of difficult choices to be made. We're working on a final draft now. We'll probably have something by early February, but I'm pretty excited about it because it really does get us to start focusing on what areas of research are we going to focus on. This austere environment medicine, caring for the underserved, what's going to be our focus there. And something that I think is really important, particularly for all of you, and I'd love to talk about this some more too, if any of y'all are interested. How do we do a better job of interprofessional education? We're lucky that we have a nursing school, a medical school, a pharmacy school, public health dentistry. We have all these different healthcare schools working together, but how often do you really interact with those other schools? You probably do some, but given that we're all mostly on the same campus, we are geographically dispersed, but we could do such a good job of not only from day one helping people from different healthcare backgrounds to learn how to work together and have that a part of our education system, and really think about what that looks like, and connect and understand, when you're talking to a pharmacist, how are they viewing a situation, and how does a nurse view a situation, and really thinking about how you work together. Because I can tell you from being in the hospital system and working in hospitals, that interactivity between the different professions is the most important thing to good quality healthcare. And it's probably the one thing we don't do very well, I think, in American medicine. The hospitals I worked in, I saw it all the time. It's amazing how problems occurred when people just didn't communicate, or they thought they knew what the other person meant by the language they used, and we missed that. We have a great opportunity at A&M because we have these different schools. We're fairly close to each other. We have a great culture and everything too. How do we build a program where we're actually having people go to school together early on, taking classes together, really learning to respect one another and understand what each other does, and actually think about how we move that into the future. And what I'm hearing from healthcare providers, the Baylor Scott and Whites of the world, and Methodist Healthcare and St. Joseph Health and others, is that that's the kind of people they want working for them. They want doctors and nurses and pharmacists to, from day one, know how to work with each other and respect each other and communicate with each other. I know when I was a healthcare administrator, that was my number one goal when I was hiring staff and leadership. And I continue to hear it from the hospital leadership that we're working with all the time. So I think that's a huge opportunity for us. And then the other thing that we're focusing on our strategic plan is realizing that we're a really good health science center. We can be so much better, but we're really good. We have lots of resources and doing lots of great things, but we sit on a campus that's one of the best research universities in the nation. We have one of the best engineering schools just down the road from us. We have an incredible agricultural science school. We have an incredible veterinary science school. We have this range of schools that touch the life sciences in so many different ways. And yet we're often kind of siloed from each other. We don't work together as much as we probably should. And so a big focus of our project, and a lot of the meetings we've had, have been working with folks at vet science and in engineering and agri-life, and really trying to think about how do we become much better partners? How do we figure out how to break down those silos? And how do we end up learning how to do life sciences across those different disciplines, whether it's vet science or agri-life or nutrition, engineering, biomedical, all those kind of things too. So I think learning to be a great partner and really learning how to leverage and understand our partnerships and what's available on the A&M campus can really differentiate us and make us a very unique, high profile, incredible health science center. And I think we're on the way there. I think people are excited about it. It's going to be difficult. It's going to be challenging. Anytime we break up silos and things, it's tricky. But I think we're putting together a plan, a set of objectives, an investment plan, a budget, and assigning accountability so that we can have a strategic plan that we can really accomplish and we can see some progress over the next 5 years. I think I'll stop there real quick, just to one, I hate to hear myself talk too much, and can't imagine that's what you guys want to hear. See if there's any questions about that. I can talk about COVID. I can talk about other things too. But let me just see if I seem to be on the right side of things, and if I'm talking about the things you guys want to talk about. So I see in the chat, I appreciate that, Ibrahim, that says, can you tell us more about the engineering medicine program at A&M? And I was reading about it, it seemed very interesting. So yeah, that's a great program. You know, we're in the second cohort of students. So we just have the second class. We'll be starting a third class here later this year. And it is the only program in the nation where you have a joint program. So after 4 years, you get a medical degree and you get an engineering degree. You get a master's in engineering and you get your MD. There are some programs that do those two programs side by side. And even across A&M, we have lots of side-by-side programs where you can get a medical degree and an MBA from the Mays Business School or whatever. What's interesting about this program, though, is that we actually developed a curriculum that's blended. So you may be getting taught by a professor in engineering or biomedical engineering or a medical professor, but the curriculum they're teaching was actually developed by engineers and biomedical engineers and medicine doctors. And so there's really thought to how do you think about, not that it's two separate disciplines you're learning about at the same time, but how do you really think about medicine with an engineering perspective? How do you approach medicine as an engineer would approach it? Or as an engineer, when you're thinking about building things and data and the way engineers think, how do you understand the way doctors think so that you can be better about thinking about how you do things? And I think people often think it's about developing devices, whatever they may be, some kind of medical device, and that could be part of it. But actually, it's also going to be about the way you think. What's the culture? How do you organize data? How do you do planning? How do you approach things? The program is taught in Houston. Houston Methodist is our partner, one of the best hospital systems in America. It's small classes. Right now, we're about 40 students per class. We'll probably grow to maybe around 60, 70 students per class. We're sort of debating that, but we do want to grow a little bit more. And in addition to all the education stuff we've talked about in this joint curriculum, there's also a very strong research component and an expectation that you come out of the program with really strong research credentials and have done some really serious thinking about innovations and ways to show what you've learned and actually be what we call a physicianeer, which is a mix of between a doctor and an engineer. So that's a little bit more about that. Happy to answer more questions. I'll keep going through the list in the chat here. Joshua says, what are some ideas and strategies to improve interprofessional communication? So a big part of what we're thinking about is how to do it from an education perspective. So how do we begin to have classes? Are there early classes, particularly in those early years, where students could take, students from pharmacy or medicine and nursing could take the same class? Some of the classes where you're learning a lot of the same thing, whether it's biology or statistics or whatever some of the courses that people take, could we do joint classes so you're not taking them separate just because you're in a different college? We're also looking at, can we start to identify ways to have faculty members with appointments in multiple schools, not only so they're teaching different types of students, but they're also interacting with faculty in a different way, and they're actually seeing about the potential for maybe research ideas and ways to work together on things. We're also talking to our clinical partners like Baylor Scott and White, St. Joseph Health, to see if there's ways that we can start working with them where we start to deliver services in a more interprofessional way. We've had a program now in the nursing school for a while that does in-home care, which is a partnership with St. Joseph Health. It's up to this point been nurses, but could we actually even rethink that program where maybe pharmacists, physicians, and others are actually doing some in-home care kind of work, which I think frankly is a big part of what the future of healthcare is probably going to look like. So we're trying to create opportunities and structures. We're doing things interprofessionally, learning how to communicate, respecting and understand the different perspectives just kind of comes natural. Interesting question from Riley. What future does your student have when they graduate from your school? That depends a lot on the student, obviously. Different students have different futures. I think A&M is really known as a place with great family medicine. As a matter of fact, U.S. News and World Report now has ranked us as one of the best family medicine schools in the country, and we have a real reputation for that. A lot of that has also been rural medicine, although what we've been talking a while now is not to just be rural, but to actually think about serving underserved populations, of which rural may be one way of that, one part of an underserved population, but there could be other populations as well too. So I think when you come out of our school, I think you have a really good chance to get strong residencies. Bader Scott White program takes an awful lot of our medical students to be residents, most of those in Dallas. And Dallas is gonna grow and be our largest campus here very soon of our medical school. And they really want to expand and grow our partnership. We just signed a new 11-year affiliation agreement with them, which is really going to grow our relationship there. And so I think there's lots of opportunities there. I'm actually in Austin tonight because I have a meeting in the morning with St. David's, which is an HCA corporation healthcare system. HCA is really interested in developing new programs with us, including residencies. And they're they're the largest healthcare system in the country. Excuse me, in the country. Excuse me. And so I think there's some real opportunities there. I think people are beginning to realize when we signed the new Bader Scott White relationship, there was a lot of press coverage about that. A lot of folks we've been talking to came to us and really got very interested in starting to ask a lot of questions about what all is going on there at A&M, because I think it sort of awoke some people to say there's a lot more going on at A&M than I thought. And so I think with some really good, strong clinical partners, that's a great pipeline to great residencies. But I know we also have, medical students who have gone on to Vanderbilt, UCSF, all kinds of different schools, military academies. And so I think there's a big future for us. And I think if we do our strategic plan process correct, and we really learn how to differentiate ourselves, where we really have an identity, that's going to improve and even increase the opportunities that are available when this is all opened up with. Last question I see on the chat is along the lines of COVID vaccines, improving communication between the media and research community. Tell me a little more. Is it Athili? Did I pronounce that correct? Diaz? Can you come on and tell me a little more about what your question was about? It sounds like an interesting question. I want to make sure I'm answering the right question.
Yeah, it's Matilli. I was just wondering, as
Matilli.
you're talking and somebody else was asking about improving intercultural communication, which is important, but I'm just thinking nowadays with misinformation and just whatever the political environment, whatever it is that you want it to be in general, how can we like improve that, like close the bridge between science and media?
Yeah. Wow, that's a great question. We could have a whole night on that probably. So that's a really good question. I think our respect for science is critical, and I think that's been lost in the last few years, which is, I think, a problem. And again, we could talk about this a lot. Some of my point of view, I was a communications guy, so I think I mentioned I did a lot of strategic communications kind of work over the years in my previous career. And one of the important things about good communications is to be as transparent as possible, and to be credible, and to be very upfront and honest and authentic. The public in general, and again, there's a lot of weird things going on right now with lots of communications, but the public can usually see through eventually inauthenticity, or if you're not being honest or transparent with them. And I think, I was actually having this conversation with some folks in the School of Public Health the other day. I think at some point, even in the COVID situation, I think we've got to be very careful about not assuming let me make sure I say this correctly. I think there were some decisions made about whether or not to wear masks and some of these other things, where there were some decisions made to not be totally honest with some folks about what we were talking about. And it allowed there to be sown kind of, questions about, did science really know what they're talking about? Specifically, what I'm talking about is some of the early decisions to not say people should not wear masks, which is clearly something we should be doing without a doubt. And it's the single biggest thing we can do right now, short of the actual vaccine, to save lives. But in the early days, there were some decisions about not doing that. I think with the theory, which was a legitimate reason, that we didn't want there to be hoarding and for frontline medical workers to not have masks, which is totally appropriate and it makes sense. But the same token, once you sort of fib a little bit like that, it makes it really difficult then to sort of get people to believe the next thing you say. And so it's a really difficult situation because, I've heard Dr. Fauci, who I have a tremendous amount of respect for, talk about how he knew masks were probably the right thing to do, but he was afraid to endorse that early on because he was afraid of the hoarding. So we have to really ask ourselves, is that really the way to answer those kind of questions and deal with the public? And do we improve ourselves in terms of long-term trust, which is really what this is about, getting people to, again, trust in science, trust in institutions, trust in their leadership, just how honest and transparent do we have to be? And as a communications person, I believe you've got to really deal with that. And it's challenging and it makes it difficult and it has all kinds of problems. So I don't mean to imply that makes it easy, but I think that's a big piece of that and a big issue. I'd love to hear if anybody has any comments about that, either agree with me or disagree, because I think this is a really interesting topic that we need to give some thought to, because I think it's critical to the future of healthcare and to the future of doctors and medical science and all the things you guys are going to be going through. Anybody willing to throw out an opinion out there on that? I see I'm being endorsed down there in the chat group. Well said, science is always changing and we continue to learn more about how to deal with things such as COVID. Yeah, and it's going to continue. I mean, you know, the complexity of science, not that, you know, sickness is getting more complicated, but our ability to deal with sickness is getting a lot more complicated. And as those things get more complicated, you know, we need to have people trust us and we need to be very honest and transparent about the way we talk about these things so that people can believe us, particularly as the way we react to care is going to get more complex all the time. And we're going to have new and more complicated ethical issues going forward and those kind of things. I just think you have to be just ridiculously honest and transparent about that. Other thoughts, other questions? Oh, that's interesting. Sue, I said my favorite part of my job. You know, actually, I hate doing it by Zoom, but I love the opportunity to get out and talk to students and to groups, not only within the university, within the Health Science Center, but I get to go out sometimes and, you know, work with external groups as well too. And, you know, I love to sell. I mean, I just love the idea of sort of telling people how, you know, why things are great. And there's so much to talk about with the A&M Health Science Center. So going to a Chamber of Commerce group or a meeting with business leadership or going to visit with clinical partners, hospital systems or whatever, and talking about all that exists at A&M. And it's interesting because there's a lot of people who don't really fully understand what the A&M Health Science Center is, you know, that we've had a medical school for a long time, how large it is, the number of residencies we have in partnership with Baylor Scott White. We have fast growing School of Public Health. We have a School of Pharmacy that's just rocketing up the charts in terms of its rankings, in terms of research. I mean, there's really a bunch of, we do more dental visits in North Texas than any single dental practice. Before COVID, we were on track to do over 10,000 visits a month up in Dallas, 10,000 dental visits a month, which is a really big dental clinic up there. And so just being able to tell to people those kind of stories and talk about that, and really beginning to sort of see, when you tell those stories, beginning to see people start to think about how A&M and the A&M Health Science Center might fit into what they're thinking about, or are beginning to think about coming to school here or whatever. So I love that part. I also just love the strategy part, just thinking about how do you, with all the resources we have, all the cool stuff we have going on, you know, it's too easy to become overwhelmed and try to do too much. And like I said, I say this all the time, strategy is about deciding what not to do. So you have to really look at all the stuff you're working on and making decisions about what to focus on, what will give us a competitive differential, and really making some decisions about, you know, what you're going to fund, what you're going to invest, where you're going to pull back investment. Those can often be very complex, sometimes difficult conversations, but when you really get a strategy that's working, and then you have an organization that knows how to operate and begins to really make things work and sticks to budgets and is creative and innovative, and we got people doing transparent, you know, we got people doing you know, patents and creating new products and everything. That's just such a rush to see that kind of stuff. So those two things are probably the favorite part of my job. Funny question from Amber, which is how do you become a healthcare executive? And it was just pure dumb luck. I was working at this strategy communications firm in Austin, Texas. I had agreed to assist the local school district down there, Austin Independent School District, with the school bond election they had. And I was real involved in helping the district kind of go through the planning for a big bond package and putting together the effort to pass the bond. At the time, it ended up being the largest bond package that a school district in Texas had ever passed. There's been bigger ones now passed. This was 20 years ago or 18 years ago, something like that. But a guy who was the head of the Chamber of Commerce in Austin, I worked with him some, and he liked working with me. I liked working with him. He had a job opening. He ran the healthcare system down there, Ascension Health, which was the largest healthcare system. And he asked me one day if I'd be interested in working on their marketing, communications, a few other things. And it was intriguing to me. And I'd been a consultant for 20 plus years and was tired of traveling. I had young kids and was tired of being on the road many days a week, and staying in Austin looked like an interesting thing. So I agreed to do it. And then just one thing came, one lucky thing happened to another. Somebody would leave a job and I would move into that job. And then before I knew it, I was running a hospital, and then I was involved with the medical school too. So just really a lot of good luck. And I think it helped that I had a lot of communications experience, because the one thing I learned in all my different jobs, and I've worked in lots of different fields, which I've been really lucky to do, is learning how to communicate, learning how to listen to people, because good communication is about knowing what people are asking for and what they're listening for. If you're good at that, and we can all improve, and myself included, but I've always just taken a communications approach to every job I've had, and it's allowed me to kind of move from one place to another and do different types of stuff. Long question here from Joshua. So have you ever faced a scenario where you had to consider transparency versus confidentiality? Yeah, how'd you approach it? What considerations in such a decision? Is it something you have to do often? So no, that is a lot of questions, but it's a really good question. So yeah, you do have, the simplest form is human resources issues. You often have situations where you're going to have to let someone go, or maybe you let someone go for some kind of problem, and yet it would be inappropriate and maybe even illegal to talk about it. So that's a real, I don't want to say simple, those are very difficult, but those kind of situations happen all the time. Where you do have the more complicated ones, though, are ones where, like the Dr. Fauci question earlier, do you tell people that they need masks, and that if you do that, you have the potential of having people hoard masks, and the people on the front lines who need masks don't have them. Those are the kind of questions that are difficult. I've been in situations, particularly in healthcare, where we had to talk about, I knew in a reality during tough financial times, we were going to have to reduce staffing, which was going to make it much harder to do certain things in the hospital. And we couldn't announce that until we'd actually been able to put things in place. At the same time, we were asking people to think about how they do their job differently. And it's difficult to do that. The trick, I think, is to be as honest as you can without crossing a line where you create new problems, but also recognize that just as soon as possible, you have to become transparent. You have to be honest, not when it's comfortable to be honest. Too often people think that you become transparent when it's comfortable or when it's easier to do. Frankly, if you're transparent, it's always difficult. You're always going to have people asking you questions. Even when I came into this job, one of the things a year or so ago when I first came in, there'd been a lot of questions about our financial situation. And frankly, a little over a year ago, we had some financial issues within the Health Science Center that were very difficult. We had some problems. I just decided we had to be very transparent. We started doing presentations to people, talking about it and admitting where we had problems and saying, this is going to be tough. We're going to have to make some changes. We're going to have to make some cuts. And it wasn't easy. There were a lot of people who were very concerned that we were going to demoralize people, and people were going to leave because they thought we were going bankrupt or whatever. The reality is most people are adults. If you're very honest with them and you explain things, they'll get it. Some people were upset. Some people were angry. But eventually we worked our way through it, and we're actually now in much better financial footing because a lot of people made some very tough decisions, did some really good management work, and we're actually on much better footing. We still have some work to do. We're on much better footing. And I think being honest about it turned out to be a really good thing, although it was difficult at times and hard to do at some point. How did I pick academia? This is another one of those questions like, how did I get into healthcare? It was kind of lucky. The chancellor called me up. I was going to go do a different job, and he called me up and asked me to work at the chancellor's office. And part of it was, I'd worked with John Sharp before, the chancellor, and the number two person at the system, a guy named Billy Hamilton's a good friend of mine. I'd worked with him. The general counsel for the system, Ray Bonilla, is a good friend of mine. I'd worked with him. And so part of it was the opportunity to work with those good friends and people I liked and who I knew were creative and thoughtful and had the right things in mind. Also, though, I have to admit, there was a part of me, you know, I mentioned when I was at Seton doing hospitals, I also got to work for the creation of the medical school at UT. And I was on the UT campus working with folks over there quite a bit. And I have to admit, being in the culture of academics was very energizing to me. I love the idea that you could, that one, you have just really smart people walking around. Not that there's not really smart people in business and in not-for-profits, but academia had a lot of people who really had great ideas. And there's also just a certain amount of expected creativity. That's not always the case, but it tends to happen more often. There's just sort of a culture of most of the time being creative, a willingness to try new things. And so I didn't really think I'd ever be in academia because, like I said, I was just sort of on the edges of it. But when the chancellor came around and offered me this job, and then in particular, when I was asked to then actually work at the Health Science Center, it was just too good of an opportunity. And I was nervous about it, not being academic. You know, I'm not clinical, I'm not academic. I'm really just an operations guy. So I was a little nervous about, you know, being accepted, understanding the language and the expectations of the culture. And it is different. It's much more different than I expected, much more different than the corporate world or the consulting world or the not-for-profit world where I worked before. But it's really been fascinating, and I'm having the time of my life. This is the best job I've ever had. I really thank my lucky stars that I found this. As someone who's interested, another question, as someone who's interested in innovation and applying to the InMed program at A&M, what are some ways one can stand out? Great question. You know, I've never been on admissions, so I've never been on an admissions committee or whatever. So I have to be honest about that. But I, you know, have either helped people who have gone through the process. I actually have a son who's a fairly new doctor, and so I got to watch him go through this process. But what I've heard from the folks who are on the admissions committees, working with the folks at InMed in particular, who I've worked with, and then being around some of the people at Dell Medical School as well too when they were doing this, is I'd actually say something that I don't think that you have to do, which is I think people think, well, I have to go do engineering classes and I have to do a ton of different things and I have to just load up my resume with all kinds of stuff and all kinds of science stuff and everything. That is important. Obviously, if you're not good at science, you're not going to be a good doctor. But what's amazing to me is what all those people in the admissions world want to know is, are you well-rounded? Do you have a life that is more than just, you know, cracking books every day? Are you creative? And how do you prove that you've been creative? What have you done that shows creativity? You know, a couple of examples. In the first UT, the Dell Medical School, the new medical school, they just had their first class a few years ago. And that first class they had, which was a really small class, they started very small. You know, they were all very smart people. They all knew science and everything, but I was amazed at the number of them who had these interesting kind of backgrounds. A couple of them had already started their own companies and had done, you know, different kind of startup work. Some successful startups, some failures at startups. They weren't all, you know, young Steve Jobs or anything, but they'd all, you know, some of them had broken out and tried to do a business. There were several who were artists, a couple who were musicians, part of a band, or who you know had did gigs, played music on the weekends or whatever, part of a band or whatever, and they had that creativity behind them. There were some who came from the political world. My son graduated from Rice, and actually, you know, smart kid, great kid. I'm really proud of him. But he actually wasn't pre-med, did not specialize in a lot of medicine or biology or pre-med or whatever. He actually was a political science major. You know, grew up in my household, very political family. We've always loved to talk about politics and all this kind of stuff. And he's always told me stories about when he was applying to different medical schools and doing his interviews. And then even when he went to do his residency, when he was applying to resident, he went to Vanderbilt as a resident, that people were always so interested in his love of politics and his knowledge of politics and how he could talk about it. And he wasn't politic like, you know, he yelled at him about what he believed in, but he was just fascinated by the process of politics. And he always said he was nervous about that, but that he learned a lot of folks that was intriguing to them. And he often had people who would tell him during interviews, I'm so glad to know that you want to talk about something. I'd love to talk about something other than just your science background or your math background or whatever. And so I've heard this from the InMed folks. You know, you would think it's medicine, engineering, you know, they want just, you know, geniuses at math and geniuses at medicine and biology and stuff. And again, they do need smart people. But what I'm told all the time by Dr. Pettigrew, Dr. Christione, and the other, you know, deans, associate deans over there, is they really are looking for, you know, who's creative, who's taking chances, who is not gonna, who can look me in the eye when we're doing interviews, who can tell jokes or laugh at jokes. I mean, it's that simple. They're looking for people who are well-rounded, who aren't going to go into the school and just freak out, or they have friends or they know how to make friends. That's important. It sounds so true, but I mean, it sounds so obvious, but it is a thing I've heard consistently from folks. I used to know the folks at UT Medical Branch in Galveston who did admissions there too. And they always told me the exact same thing too, that they really wanted to see people who were well-rounded. So I've seen some notes in here that people are agreeing with that. That is so true. And the fact that you're in a group like this, I think it's good. Hopefully you do have friends, you are interested in other things. Don't feel like you have to go in there and impress them that you're, the greatest doctor in the world. Go in there and let them know that you're happy with your life. You're excited about the future. You're willing to take chances. You want to be creative. You have friends. Those are the things that they want to hear about. Great questions. Anything else? This is interesting. I was afraid I'd come in here and wouldn't have anything to say, and I'm probably talking too much, but you guys have had some really good questions. Anything else? Anything about COVID or any of those kind of things that anybody's wondering, any questions or anything about that? Anything about where you get to park? Do you need a better parking spot? Or, this is your chance to ask anything. Oh, okay. Where do you see the future of healthcare administration? Okay. How do you see entrepreneurship? Great question. So I love to talk about this. So I think the future of healthcare administration, the business of healthcare is changing dramatically. When I first went into healthcare, which again was probably now, if you add everything up, about 17, 18 years ago, the economic model didn't make sense to me. I'd done a lot of business stuff. I'd worked in the corporate world. I'd been involved in small businesses. I'd been involved in not-for-profits. And there was always a direct relationship between the company I was working for and the customer. Well, healthcare, if you haven't thought about this already, is different right now. You have your customer, your patient. And again, I know it's important that they're a patient and everything too, but they're also a customer just for the sake of this conversation. And you have you, the provider, but the relationship between the patient and the provider has this other player in the middle, which is the insurance company. And whether that's Medicaid, Medicare, or commercial insurance like United Healthcare or Blue Cross Blue Shield or Aetna or whatever, the way you get paid is driven by the way that insurance company contract works. And so while we often like to think about how the providers, whether you're a doctor or a nurse or whatever, and the hospital has to make the customer happy, that is important. But unfortunately, the way we're structured, you have to make the insurance company happy. And I don't say that to say I'm not bashing insurance companies. I'm also not trying to say that it doesn't matter what happens to your patients, but it is a weird kind of system where the person you're serving is not really directly paying you most of the time. Again, I know some people pay cash and those kind of things, but most of the time, the person you're serving actually doesn't write you a direct check for care. It's actually the insurance company that's going to pay you the bulk of the care. So it kind of changes the incentives a little bit and the structure of how you're going to think about things. And I think that has been difficult and a problem for healthcare in the country for a long time, because that's kind of what's been going on is insurance companies and providers, and in particular hospital companies, kind of worked in cahoots with each other. And again, I say cahoots, not trying to accuse anybody of being dishonest or whatever, but that was where the relationship was. And often doctors and the providers were not really brought to the forefront to really consider about how things can happen. That's really beginning to change. And there's some healthcare providers out there, systems, that this is a huge priority to. For example, Bader Scott White, who's our big partner, one of the things I love about them is that they still have some corporate characteristics to them, but they really are trying to figure out how to really be much better about serving that patient. And part of the reason they're able to be a little bit better because they're both a hospital provider and an insurance company. So they've been able to blend those people a little bit more, which I think is really interesting. So there's not the totally disconnected relationship, but they're sort of blending that, and they're trying to figure out how to be a better provider while they're also providing insurance to people. I think the future of healthcare is going to change pretty dramatically as we go forward. I think the model is going to change. I think a lot of what's been going on with COVID, with virtual care and those kind of things is going to change. I think there's some really interesting innovations going on. For example, Amazon Care, what's going on up in Washington State, where the Amazon Corporation has created their own primary care delivery system. And they have primary, if you're a patient, if you're an employee of Amazon up around Seattle and all where they are up in Northwest part of the United States, your primary care is provided by something called Amazon Care, which is their own system. There are no clinical buildings. These doctors don't work in clinical offices. They use the same logic and the same algorithms they use to do deliveries. They use those to deliver healthcare. So if you're one of these employees, you can be at your office, you can be at home, you can be anywhere. You can go on your phone, go to the app, tell them you feel sick. They will have a doctor or an APN, an advanced practice nurse, come to your house, come to your office or whatever, triage you, figure out what you need. If you need to go to a specialist, they'll make sure that happens, and then they have a relationship with specialists in town. But they will make that decision without you having to leave your home or your office. Hopefully they can take care of you at home. If you have pharmaceutical needs, they actually have vans that are moving around like Amazon vans that have pharmacy supplies in the back of them. They'll actually come to your house or your office and deliver your prescription within 2 hours. They're in the process now of developing roving imaging vans so they can actually do imaging for people. I mean, it's really amazing. And they've just turned the model upside down, where they basically have taken the insurance company out of the game to some extent. Again, if you're going to need open heart surgery, you're going to probably have to have insurance to pay the cardiac surgeon, but they've turned the model upside down, and they're really thinking about delivering care by reducing cost and friction of a system and delivering care directly to people by using the science that they've learned through their delivery process, their algorithms and so forth, to do a great job that Amazon does. Now, is that the answer to everything? Probably not. But I think it's a really interesting model. And there's a bunch of other models like that. There's another company on the East Coast that's actually providing intensive care services at the home. So they actually, instead of keeping you in a hospital for a week while you're on ICU, they set you up in your home, something that looks like an ICU bed, and actually provide intensive care services, which is one-on-one service anyway, actually in your home, and try to reduce the cost of hospital care, but still provide high quality care for those kind of patients where it makes sense. You guys have probably heard about concierge care, where we have systems like this or practices like this in Bryan College Station right now, where people pay $100 a month. You have a physician who has no more than 500 patients, maybe total, a very small panel of patients. And that doctor is basically on call to you. If you call them and say you've got a problem, they're going to react to you immediately because you pay them this $100 a month retainer, basically. If they need to do more, they may need to charge you for other things, but you're paying them directly, and that's your physician service, that's your medical care service. Again, beginning to take insurance companies out of the way. So I think that's going to begin to happen. It's already happening with physician providers, nursing providers. I think that begins to change what hospitals look like, and I think we're starting to move down the path of a very different kind of healthcare administration going forward. So I can talk more about that. Like I said, I can talk about that forever because I'm very fascinated with that. But I want to go to some of the other questions we're having that are being asked in chat here. Do admission committees factor in the difficulty of undergraduate degree when they look at the applicants' extracurriculars? Again, I haven't been on an admissions committee. My gut tells me I've never asked a specific question, but I mean, I think it's an issue. I mean, I think if you go to a not respected school, that's going to be more of a problem than if you went to a well-respected school. But I don't think in their minds they're thinking, oh, this person went to, Rice, and this person went to Texas Tech. Rice is better than Texas Tech, so I gotta rate them higher. Part of that's my own prejudice too. When I hire people, if someone tells me they went to Rice or whatever, and somebody else told me they went to Texas State, that to me doesn't matter because there's so many other things that are so much more important than what school they went to. I mean, it's good to know you went to a great school, that's wonderful, but you could still have all kinds of issues when it comes to creativity or innovation or whatever that you may have actually been able to do better in maybe a smaller school or a less, a less prestigious school because you had better access to faculty maybe, or you're able to work in the community or with a business or something like that. So I don't think that's as big a deal as sometimes I think people think. Next question, perspective on the current COVID vaccine. Well, there's 2 COVID vaccines. I think they're both great. They're very difficult to distribute. That's what I've been spending a lot of time the last few days trying to figure out, because you've got the keeping them very low temperatures. Once you open it up, you've got to use it in a very short amount of time. We've also got distribution model problems where we're not getting enough out quick enough to enough people. So there's all those distribution and logistics problems, which I think we're starting to figure out how to fix. And my guess is the federal government's going to start to nationalize this a little bit more, which I think will help to get a lot more shots in arms over the next few months. I know the Biden administration is committing to 1 million a day, which I think is very doable, but it's got to be on a different kind of platform and approach that we're taking now. On the vaccine itself, I am absolutely 100% confident. I plan on getting a vaccine as soon as I can, which will probably not be till March or April, whatever. But I'm a big believer in it, and I've got some relatives who have tried to argue with me. They don't think they're going to get it, and I just bang on them that I think they're absolute idiots and they should get the COVID vaccine as soon as they can. I'm a big vaccine person. I think they really do work, and it's important that we do it. And I think when it comes to the COVID issue, we really got to take it seriously. What do you recommend to college students who want to help our families, friends, coworkers not be so distrustful of the vaccine or science? Great question. I know a lot of people I've spoken who are very wary about the vaccine because it came out so fast. Really don't feel like I have the best communication skills to convince them. That's a great question. And I don't think this is easy, but I will. One of the things I explain to people when they ask me this, how could it come so fast? Before this, the fastest one ever was the mumps. I think there's 2 things that make this a little bit different. And I don't know if this, is going to solve everybody, but make everybody, believe it right away. But it's 2 things that I tell people all the time. One, the speed to market here. It wasn't so much that they skipped steps. What Operation Warp Speed, which you've probably heard about, which the federal government did, what Operation Warp Speed basically did is said, there's a whole bunch of steps, the beginning of an idea for a vaccine all the way to getting it manufactured and to getting it delivered to hospitals. There's just hundreds of steps. What they did is kind of bundle those different steps into some sections, and they start doing multiple steps at the same time. So I'll give you a really easy example. You may know that we have a facility here by the Health Science Center that's run by Fuji North America, but A&M Health Science Center is a partner in it, and it will be the manufacturing site for the Novavax vaccine, which isn't out yet. It's in late stage 3rd phase trials right now. But it looks like it's going to be successful. It may not be at the 90-95% effective level, but it's probably going to be 80-85% effective, which is still pretty good, when you compare that to what our flu vaccines often are or whatever. It's a different technology and everything too, but it'll be coming out theoretically, say March, maybe something like that. We are already at that facility producing the vaccine, even though it's not officially approved. And the reason we're able to do that is because the federal government, as a part of the Operation Warp Speed, actually front-ended the money that we get and that Fuji gets and so forth, saying, okay, we're going to go ahead and pay you to start producing this vaccine. We know we're taking a risk because theoretically it may not be found to be effective, but we feel comfortable enough that it's going to be effective. We're going to go ahead and jumpstart all these steps, pay for them early and get them done sooner. So it isn't that steps were skipped. It's that steps were all paid for and pushed to be done at the same time. So while we were getting ready to start manufacturing, another company in the chain was getting paid to develop the glass vials. There had to be a whole different glass technology figured out to deal with the massive number of vaccines we have to get. So they were paying Corning Glass Company a lot of money to figure out the glass problem. They didn't wait until it was time for glass. They were paying them the same time they were doing that, the same time they were paying us to build out the manufacturing facility, and they're paying lots of other folks. So when people worry about the time, what it was an amazing trick of logistics, not skip steps. The other thing is that particularly with the Pfizer and Moderna vaccines, it's a new technology, and all of y'all on this call are much smarter than me when it comes to this kind of stuff. But it's a new form of biological approach to vaccines. It's been something that epidemiologists and folks who work on vaccines have been thinking about for a long time, this mRNA process. And so they were already beginning to play with this. And there was some feeling, from what I understand, is that very soon we were going to be doing normal flu vaccines using this mRNA process. What happened is when the COVID came up, a lot of people doing that realized we can do this mRNA process to deal with this COVID problem. So there was a lot of great science being developed, they thought, for flu vaccines, and they sort of realized we can take that technology and do it to take care of this COVID. So we were sort of lucky there that we were able to sort of jump the science really quickly. It wasn't steps being skipped or anything else. It was just sort of the being fortunate enough to have this new technology that was already being tested, already being trialed in different ways, and we're able to jumpstart it very quickly to go with the COVID stuff. I want to be cognizant of time. I know there's just a couple more minutes, and I appreciate you guys giving me this hour. This may be the last question, but again, if there's anybody else, be happy to answer another one. But talk about a monumental moment in your career that changed your perspective. Talk about helping people in financial difficulty. So maybe more in any philanthropic projects. I've been lucky to have a lot of great moments where I had great mentors. What I've really been lucky is to have a lot of folks who were really smart, who were willing to spend a lot of time helping me when I entered a new area, whether it was management consulting or corporate strategy or hospital, or now that I'm in academics. I've been really lucky to find people who are willing to kind of understand that I didn't know always what I was thinking about, and they helped me sort of think through the process and do it. So I'd say, as opposed to a monumental moment, I've had monumental mentors. So I've really been lucky about that. I can name, a dozen of people who really affected my life pretty dramatically. I guess monumental moment, I had a lot of time in politics. And again, I know politics, what I'm talking about, it seems so distant from each other. And in many ways they are. And modern day politics have gotten much more difficult to swallow sometimes. But I learned a lot about communication and persuasion, and how do you use persuasion to convince people to do things as opposed to an assumption of authority. And as I've gotten more into roles where I actually do have some authority and some titles and so forth, I had one of those mentors I talked about said, you can always choose to use authority to get things done, or you can use influence and persuasion to get things done. And it's always smarter to use influence and persuasion. And I totally believe that, because if you think you can use your authority to get things done, you may get some things done certain times, but it's going to fail you at some point, and you're going to make people angry, and people are going to have less respect for you and other things. If you focus really hard and listen to people, and you figure out, how do I persuade people to be for this? How do I convince them this is something that's in their interests, and we can work together on this? If I really listen and figure out, what that customer wants, what that person out there I'm talking to wants, and figure out how to develop something that scratches their itch while it also scratches my itch, it's very useful. And that's a skill I think I learned in doing politics that has just always kind of stuck with me. And I think it's helped me in being in a lot of different situations to always think about that. I had one of my mentors in politics told me that if an audience is listening to you and they're not understanding your message, it's always your fault. It's never the audience's fault. You have to figure out what the audience wants to hear, and you got to figure that out. And it's a constant job to figure out what's going to make them interested. And so I try to think about that all the time. I hope I did that with you guys. I hope I figured out to talk about some things you guys want to hear about. And this was hopefully fairly interesting and met your expectations. But I try to do that always. Like, what is it people want to hear? And how do you persuade people to do things as opposed to using the authority to make them do something? So I don't know if I answered it exactly, but to be honest, that's been what's more monumental to me, is those learnings as opposed to any certain moment in my career. I think I'm gonna stop there. Maybe Rudy or someone, just see if there's anything else. I don't want to go past time if that's inappropriate. I know an hour of y'all's time, as busy as you are, means a lot. So I want to be respectful of time.
Yeah, if there's no more questions, it looks like we're nearing the end of our time. So thank you so much, Mr. Hartman, for taking time out of your day to join us. And for the rest of our members, we have a virtual shadowing session next week, and I'll post the registration link in the chat. Have a good night, everyone.
Thank you. Let me just mention, I just put in the chat box my email address. If anybody has a question they didn't feel comfortable asking or didn't get a chance to, or anything else, feel free to email me. I'd love to, we can chat by email. We can even talk by phone at some point, or whatever we need to do. Good luck with what you guys are doing. Y'all are the future, so it's really important. So I really appreciate this chance to talk to you. Bye-bye.